Good morning, welcome. Today I think will be a fun, interactive day, just a half day, but I think you'll really enjoy, John's not here yet, but you'll really enjoy the talk this afternoon by John, the lunch, and then this morning's very interactive program on CAM training, which I think we saw this a lot yesterday when people spoke, but how I was really struck by Rich Jones' slide on reliability, how important training is, and I'm sure Ed will talk more about that as a piece, so we're thrilled to have him. I shouldn't have to read this at all because I've been lucky enough to know Ed for a while here, but Dr. Ed Marcantonio is a professor of medicine at Harvard Medical School. He serves as section chief, which you might not know that, for research in the Division of General Medicine and Primary Care at BI. He also leads the Division Aging Research Program. He is really internationally recognized expert, clinical investigator, and thought leader in the field of delirium. He is also, had several, been continuously NIH funded for a very long time, had several large studies on intervention studies for delirium, targeting both individuals at risk, identifying modifiable risk factors, testing interventions. He currently, I may tell you more about this, but he has several studies. He's also become an expert on biomarkers in delirium, which is a really important emerging area. He's the lead investigator and author of a tool called the 3D Cam, which you'll hear more about. And I've been lucky enough to be with him on a study that we're just completing right now, a 4.5-year long study looking at a 2-step delirium screening process. The other thing, and write this down, is to look up his editorial and to use it in every class you teach. I just love it. It's very well written. It just came out in September in JAMA Internal Medicine, I think. Annals of Internal Medicine, and it's called Old Habits Die Hard. And it's about the recent AHRQ report on antipsychotics and delirium. And Ed is really also a rock star and a leader in his field in terms of this work. So please welcome him.
Thanks, Donna. And thanks to Donna and Eva and Liz also for your great coordination and planning of this conference. So as Donna said, this is going to be a pretty interactive session this morning, and hopefully all of you had a chance to download the Poll Everywhere app on your phone last night. If you haven't, try to do so before we start. And we'll show you we'll give you, when we start the poll, we'll give you the login, and we'll be doing some both targeted questions and then also having you observe a delirium assessment and score it, and then we'll go over it together. But before we do any of that, we'll start with a little bit of didactic just to get everyone up to speed, and hopefully this may be review for most of you. We're going to talk about the CAM and the 3D CAM, and really take a pretty deep dive, like Sherlock Holmes, into the nuances of the CAM, and there'll be time for questions as well. But before we get into the CAM, I did want to have a couple of overall slides about talking about delirium measurement and research studies, and just to point out that one size does not fit all. So I wouldn't say that it's appropriate to get comfortable with a single instrument and use it in all your studies. Different instruments may be appropriate for different studies that you're doing. So when you start any study, it's important to consider these questions that I have up here very carefully. What kind of instrument to use, what instrument to use, how to determine the presence of delirium and severity, who should be performing the assessments, how often to perform the assessments, when to perform the assessments, And as I said, the answer may differ from study to study. What I would say as a point of caution, as I heard a lot of your grant proposals, is if you're doing a detailed pathophysiology study of delirium, you probably don't want to use a brief screening instrument for your determination of delirium. You probably want to use a pretty detailed approach like what we'll go over today, like the long CAM. On the other hand, if you're doing a quality improvement study or just trying to improve recognition on the wards, then obviously a simple screening tool is the appropriate study to use. You also want to titrate to the population. So it may not be best to use the CAM ICU on the general medical floors or in nursing home patients. On the other hand, it's probably not appropriate to use a long CAM in the ICU. So all these have to be taken into consideration. Also, as Donna said, we won't really go over this, but QI of your assessment, training and QI is so important. So you will want to train your staff on how to do these assessments and then observe them directly to be sure they're doing them correctly. And we like to use inter-rater reliability. So we'll have two assessors go into the room at the same time and simultaneously assess the patient. One does the interaction, the other just sits and scores. And then we'll review those both for the presence of or absence of delirium, but also for severity and for even drill down to the individual features. So think about all of that as you design your studies. It's important to know, and Rich Jones teaches me this all the time, I always say we're going up on the wards to diagnose delirium, and we're actually not in the context of research studies. I guess if you're a clinician on the, on the clinical service, you're diagnosing delirium, but in a research study, you're actually making a research assignment of delirium presence or absence. So particularly if you use non-clinicians, it's important not to use the term diagnosis. Even potentially, and maybe Donna or Priyanka could talk about this, even if you're working with nurses, can get a little nervous if you use the term diagnosis. In certainly NPs diagnose, but other nurses say, well, diagnosis is not part of the scope of nursing practice. But again, the goals, and I'm sure you've all, from your basic research training, know the goal is high validity and high reliability. So if you think about the target, validity is do you hit the center of the target, and reliability is are all your assessments clustered closely together. So you want to hit the center and be closely together and be able to prove that in your publications. Okay, so now turning to some assessments. This is just a partial list of over 40 delirium assessment tools that are in the literatures that will render a presence or absence of delirium. The CAM-based methods are at the top, the standard CAM, the CAM ICU. Then you can see there are a whole variety of other assessments. Some are primarily geared to severity, but will also give you a presence or absence. Others are geared primarily for determining presence or absence, but can also give you a severity score. But there are a lot of tools out there. The other point is when you're doing your studies, and I saw a little bit of this yesterday, don't take the approach of, well, I don't want to annoy anyone, so I'll just say I'm going to do 5 of these assessments in my study, and that way I'll please everyone. Well, in fact, you'll probably please no one with that approach. So carefully consider your choice and justify it and say, I'm using X, and I carefully considered Y and Z, but I chose X because of these reasons, and justify it, and I think that's the best way to go. So today we'll focus again on the CAM. It is the most widely used tool worldwide. It's been used in over 5,000 research studies. It's been translated widely. There's actually some confusion about the CAM, which I'll try to clarify today. So there's both a short CAM, which assesses just 4 diagnostic features, and the long CAM, which looks at all 10 features. The long CAM provides a lot more information, particularly around phenotypes and severity, and can be used as a research standard and tools. So in the READY study that Donna mentioned, we're using the long CAM as our research reference standard. So we'll focus on the long CAM because it's the most complicated instrument. So if you understand the long CAM, you'll understand the short CAM too. And then we'll also briefly describe the 3D CAM. So the CAM was developed in 1988. Sharon has a very interesting story around how the CAM came to be, which I won't repeat today, but if you ever see her, ask her to tell you about how the CAM came to be, and you'll have an entertaining story for about 15 minutes. But it was designed to enable non-experts to be able to assess delirium. In the 1980s, delirium was pretty much in the realm of expert psychiatrists, and the idea was to try to bring it to availability for other clinicians. It was based on DSM-3R criteria. All of the features are part of DSM-3R, but it's proven to be relevant for subsequent DSMs, the DSM-4 and 5. It is a copyrighted instrument, and Sharon requests that it's cited if you use it in any of your work, and the citation is there and in your slides. It is, I think it's got, the original CAM paper has over 4,000 citations now, so it's one of the most widely cited papers in all of the medical literature. So this is the CAM diagnostic algorithm. I'm wondering if I should use this so I can move around a little bit, or, well, anyway, can you all hear me?
Yes.
Okay, I have a pretty loud voice. So there are 4 key features of delirium within the CAM for diagnosis. So feature 1 is acute onset and fluctuating course. More commonly operationalized as acute onset or fluctuating course. You actually don't need to have both. Either will trigger feature 1. Feature 2, inattention. Feature 3, disorganized thinking. And 4, altered level of consciousness. And you must have features 1 and 2 and either 3 or 4 to have delirium by the CAM. And this has been shown to be highly sensitive and specific when applied, but with adequate training. It's actually been shown to be not very sensitive when it's applied by either clinicians or researchers without adequate training. So the CAM diagnostic process is in this flow diagram. So you start with a formal interview of the patient, which should include some cognitive testing. You may also seek additional information from the family or from a nurse, particularly if this is your first time seeing the patient and you don't have a baseline. You then use the interview to score the CAM long form, which is 10 items. Then you pick out the 4 diagnostic features to determine the presence or absence of delirium, and then you get the final result of delirium or no delirium. So we'll actually, in the next session, we'll go through this process exactly as in the diagram. So a little bit about cognitive testing, because some places have actually just put the CAM in the medical record and said fill out the CAM, but don't specify how to do it. So it's been shown that if you just have people fill out the CAM based on routine observations from clinical care, the sensitivity is not very good, probably under 50%. So you really need, because the CAM isn't really an interview, right? It's a diagnostic algorithm. You don't go up to a patient and say, are you inattentive today? You have to do something to assess whether they're attentive. So you have to ask some questions. So it's best if the CAM is scored during an interview that includes some cognitive assessment. Now the assessment can be brief. For instance, you don't have to do the MOCA. The MOCA is probably more than you need. But it should include some testing for attention, orientation, and memory. Particularly if you want to score the long CAM, you do need to assess for memory as well. Some common tests that are used, the short portable mental status questionnaire, the mini-cog, days of the week, months of the year backward, digit span are all used as tests of attention. You know, I think we can always use better tests of attention, so that's a worthy goal, particularly one that could flex depending on a patient's baseline abilities. So then you score the CAM, you use the cognitive testing, plus the observations that you make during the cognitive testing to score the CAM. Some general interview guidelines. You want, as best possible, these are hospitalized patients that are often on a busy ward, so it's kind of crazy, but you want to try to create a quiet, calm environment. We ask our researchers to check with the nurse and make sure that the patient isn't about to get taken off for a CT scan or something like that, that we have like 10 or 15 minutes uninterrupted to spend with the patient. We also ask them at that time whether they've noticed any acute changes in the patient's status. If they're family members, we usually ask them to leave the room while we assess the patient. I always say there are two types of family members. There's one type of family member that tries to give the patient hints during the interview, and there's the other type of family member that chides the patient because they're getting everything wrong. Oh, come on, Mom, you know what month it is. So neither of those type family members are useful for you in your assessment. So that's why it's good to ask them to step out if you can. Obviously, make sure the patient can see and hear you. Sit down rather than hover over the patient. We supply all of our interviewers with a pocket talker. Often patients with hearing aids leave them at home in the hospital so they don't get lost, which is it's probably a bad idea, but unfortunately they do get lost. So we have these pocket talkers, which is an amplifier to help with testing. They're pretty inexpensive, under $100. You can get them on Amazon or other places. Also, don't give verbal praise or indicate correct or incorrect answers. We instruct our research team to make lots of notes during the interview. So if they have any questions later, they can bring them to the team to review, and we'll show some examples of this. It's actually on this slide. But now we've gone to direct data entry with REDCap. We don't use paper forms anymore, so you have to actually allow a separate comments field after each question to be able to do it in REDCap. So now they type the notes into REDCap. Record the patient's exact words if possible and avoid interpretations. So some examples here. Instead of respondent disoriented, write respondent said she was on a ship in Hawaii. Or instead of seems inattentive, say, could not make eye contact, attention darted to every noise in the room. Okay, so that's some general guidelines. Now we're going to just go point by point through all the 10 CAM features. And again, hopefully this will be a review for many of you, and then you're going to use these in your scoring of the assessments that we do in the second part of this talk. So first, a little bit about the scoring of the CAM. So each CAM feature, besides feature 1, is rated, has 3 levels: not present, present mild, or present marked. Acute change and fluctuating course is just considered present or absent. So mild rating means that the behavior was present or observed at some point during the interview, with 2 exceptions, which we'll go over in a couple minutes, but did not significantly interfere with the interview. Whereas marked means that the feature was present and did interfere with the interview. It made it difficult, interrupted, prolonged the interview. So now to the features. So acute change, and again, these are quotes from the actual CAM instrument. Is there evidence of acute change in mental status from the patient's baseline? This is positive if the patient demonstrates or reports a change in mental status, assuming that you can establish a baseline. This can either be a new symptom or a worsening symptom in intensity, and we're talking about hours to days here. So if a family member says, oh yeah, my mom's been going downhill for the past 6 months, that would not qualify for acute change. It has to be something within the past, usually I use the framework of 2 weeks. Have you noticed any changes over the last 2 weeks? Because sometimes it can be several days in coming on. Or compared to 2 weeks ago, how is she doing? Oh, much worse. The evidence can come from the interview itself. The patients can sometimes report acute change, from medical record review, from the nurse or physician, or from comments from family members or visitors. The second half of feature 1, fluctuation. Did the behavior fluctuate during the interview? Key things that can fluctuate are attention, disorganized thinking, altered level of consciousness, or psychomotor agitation or retardation. If you have both agitation and retardation in the same interview, then you've got fluctuation. That's a good way of thinking about it. And fluctuation is whether the symptom comes or goes, or increases or decreases during the interview. So a couple of pearls on fluctuation. One is, what's the difference between acute change and fluctuation? If it changes between interviews, I call that acute change. If it's within the interview, I call it fluctuation. And within the interview, one way to think about it is cut the interview in half, and is one half markedly different from the other half? If so, there's probably some sort of fluctuation in one of the features. So on to inattention. Did the patient have difficulty focusing attention? For example, being easily distractible, having difficulty keeping track of what's being said. And this can be both difficulty maintaining attention or also shifting attention appropriately to new stimuli. Often the respondent seems unaware, out of touch with the environment, dazed, fixated. You have a hard time engaging the patient. It's difficult to establish a back and forth conversation. You might have to repeat questions over and over again. They'll be like, what was that? Can you say that over again? Or it could be from errors on the attention tasks, if you include attention tasks in your interview. Disorganized thinking. Was the patient's thinking disorganized or incoherent, such as rambling or irrelevant conversation, unclear or illogical flow of ideas, or unpredictable switching from subject to subject? This is when the patient speaks incoherently, rambles, irrelevant conversation, tangential, circumstantial, or faulty reasoning, off-target or nonsense responses, and the patient must be able to speak to assess this feature. So disorganized thinking, in my opinion, is one of the two hardest features in the CAM to assess, because there's no individual cognitive test for disorganized thinking. And the other thing I would say, which maybe is a little bit harsh, but in my opinion is true, is that there's a certain level of disorganized thinking ambient in the world. So if you talk to people, sometimes they are a little rambly and tangential and hard to make sense of what they're saying. So the question is that kind of normal, or is it abnormally disorganized? And that can be a little different from person to person. So this is a really good one for your assessors or for you to write down exactly what was said and then review it at a later point and agree, yes, that was disorganized, or no, it wasn't. Altered level of consciousness. Overall, how would you rate the patient's level of consciousness? And can be alert or normal. Vigilant, which is rare but important to recognize. This is when someone is overly, it's like if you drank 20 cups of coffee, like you're overly sensitive, jumpy to external stimuli. Lethargic is sleepy, slightly reduced level of consciousness but easily aroused. Stupor, markedly reduced level of consciousness, difficult to arouse, and obviously coma is unarousable. So a couple of points on altered level of consciousness. One is that, you know, as those of you who've worked in hospitals, everyone seems to be sleeping at the wrong time, right? So everyone's sleeping during the day and everyone's wide awake at the middle of the night. So if you go in the middle of the day and the patient's sleeping and you have to wake them up, that doesn't count against them. They actually get one free wake up. That doesn't count for altered level of consciousness. But if you have to wake them up a second time, if they fall asleep on you during the interview, then you do count it. The other thing is there's sometimes some confusion between altered level of consciousness and psychomotor retardation. So the difference is that the level of consciousness relates to the level of arousability or responsiveness, whereas psychomotor retardation is more how quickly people respond to a stimulus. So someone can be totally awake but be really slow, and that would be psychomotor retardation. It wouldn't be altered level of consciousness. Donna?
I was just going to, it's sort of a question for the group to comment, because this is what I think that when we first started working together, that this was an interpretation of the CAM that I had interpreted differently, and I also see that clinicians do too. I wonder how many here see like sleepiness as altered level of consciousness versus like you have to be asleep, snoring, sort of. Was this a surprise or not? That you really have to.
Yeah, so the point is that if someone just says they're very sleepy but doesn't actually fall asleep, we wouldn't call that altered. They actually have to fall asleep.
Or if they're like not, like some of you might be by this afternoon, if you're nodding off, that's not altered level. Right?
Well, it depends. Some people actually do fall asleep at that. So if you notice someone's falling, I guess if you notice someone's falling asleep, so part of it also is how you conduct the interview. If you notice someone's falling asleep, I might not like immediately try to arouse them. I might kind of slow down and see what happens. And if they do actually fall asleep and you have to wake them up, then I would count it as altered level of consciousness.
Thank you.
Yeah.
About that. So for
Yeah.
the interview, and then falls asleep frequently, then that also counts as an
Right.
intervention.
It's hard to be attentive when you're falling asleep all the time, so you may get 2 for that. I mean, rarely someone falls asleep, but when they wake up, they're totally attentive, but I'd say that's pretty unusual.
So is it fair to say then that the first component is sort of a baseline, because we're essentially assessing level of consciousness in 3 times during the CAM, right? So the first component is kind of a baseline. Have they changed over the past 2 weeks, say? Then within the second half of the first component, there's, have they changed in the last, at any point in time during the interview? And then this component is also, have they changed at any point in time during the interview?
Well, this is not, so there are 2 things. There's acute change and there's altered level of consciousness. Altered level of consciousness is just what you see during the interview. You just rate it based on one of these things. But for acute change, yeah, you would want to compare it to the baseline. But I would say altered level of consciousness is one of the easier ones, because most people don't have an altered level of consciousness at baseline. So if you see an altered level of consciousness in your interview, it probably is an acute change.
Here's the other one I think I like to say about dementia, because I focus a lot on DST, is and maybe this is more clinical, but I try to tell nurses that, it's altered. I think a lot of people assume altered level of consciousness is okay in a person with dementia, and it's just not.
Right.
Just,
Yeah, I mean, altered level of consciousness is sustained until very advanced dementia. I should say that pretty much everything that we're talking about excludes advanced dementia.
or end of life.
So, right. Well, end of life, they're probably delirious.
Yeah, no, you're right.
But for advanced dementia, I don't think we have good tools for assessing delirium and advanced dementia yet. But I think what we're talking about will hold for up to moderate dementia.
I've just got a question about differentiating delirium from encephalitis. Would you consider them to be separate, or would you consider an encephalitis to be
Yeah, so that's a really good point. So you just code things as you see them, regardless of etiology. So I would guess that 98% of people with an encephalitis have delirium. But often we'll see clinicians say, oh, that person's in renal failure. They don't have delirium, they're in renal failure. Or they just got a pain med an hour ago. They're not delirious, it's just the effect of the pain med. Well, you have to sort of totally reshift your thinking and say, no, they're delirious because they got a pain med. They're delirious because they're in renal failure. They're delirious because they have encephalitis. So just because you can identify an etiology doesn't mean it's not delirium. In fact, in the DSM-5 criteria, having a medical etiology or a drug etiology is one of the requirements for delirium. So, yeah, just code it out as you see it. One other point on altered level of consciousness. There are some patients who just, I think, don't like the fluorescent lights in the hospital and keep their eyes closed all the time, but they're totally awake and answering all your questions. So if that's true, obviously that's not an altered level of consciousness. So those are the core diagnostic features. Now we'll move on to the additional features. Disorientation. Was the patient disoriented during the interview, such as thinking he or she were somewhere else other than the hospital or the wrong bed or misjudging the time of day? Disorientation to time, place, or person. Often patients will think they're at home, or they'll say that it's nighttime rather than daytime. They'll mix up their meals, not realize the time of day. Obviously, errors on orientation questions. Memory impairment. Did the patient demonstrate any memory problems, such as inability to remember events or difficulty remembering? And this could be learning new material or remembering past or recent events. Can't remember why or how long they've been in the hospital, why you're interviewing them, or errors on recall tasks. Remember, it doesn't matter. This is one where, you know, patients certainly with dementia will have memory impairment. So this is coded whether or not it's their baseline or not. It's just present or absent. Perceptual disturbances. Did the patient have any evidence of perceptual disturbances, for instance, hallucinations, misinterpretations, or illusions? So I mentioned there are 2 CAM features that don't require that you observe it during the interview. This is the first one. Perceptual disturbances, we allow for patient self-report within the past 24 hours. So if the patient said, I don't have anything now, but last night I was hallucinating such and such, that can be used for this feature. So this is present with visual, auditory, tactile, or olfactory hallucinations or perceptual disturbances. Or even if the patient says no, but then you see them turn and start talking to someone else and there's no one there, you can count that as well. That's observation. So it's self-report or observation. And just to differentiate in your mind the differences between the perceptual disturbances. So hallucination is when someone perceives something and it's just not there. So they see something that's not there, they hear something that's not there, they feel something that's not there. Misinterpretation, an object is there, but it's not what they think it is. So they think they see a bundle of clothing and they think it's a person, for instance. Or illusion is when the object's there, they recognize it for what it is to be, but it's strange or distorted in some way. So there, the classic one is often people will think like the walls in their hospital room are collapsing on top of them, or they'll see wavy lines, you know, they'll think that something's moving that's not moving, or is wavy or distorted in some way. It's actually quite common. Often in post-op patients. So psychomotor agitation, did the patient have an unusually increased level of motor activity such as restlessness, picking, tapping, frequent sudden changes in position? This is greatly increased relative to the norm, restlessness, increased speed of it, and it's psychomotor, so it's not only how they're moving, but how they're responding to your questions. So if they respond incredibly quickly, and it may be voluntary or involuntary. And the opposite, psychomotor retardation, is when the patient has abnormally decreased or slow responses, sluggishness, staring into space, staring in one position for a long time, or moving slowly. So if you ask the patient, let's say you ask the patient a question, like, what year is it right now? And they're kind of sitting there. So this is when it actually pays to take your time with these interviews. And they don't say anything. That could be probably inattention. But if they pause for a long time and then they say, 2019, and it's like, whoa. That would be psychomotor retardation. So that would be the difference. But you have to wait to see it. So oftentimes the way we interact with patients damps down, and this might be some of the reason why the untrained interviewers don't have a lower sensitivity of delirium. If you kind of jump in, like physicians are supposed to give patients like 1.5 seconds before they interrupt them. You know, if you jump in 1.5 seconds, you might miss some of these. So it's important to wait. The final one, the final CAM feature is sleep-wake cycle disturbance. Did the patient have evidence of disturbances of sleep-wake cycle, such as excessive daytime sleepiness with insomnia at night? So this is the second CAM feature where you allow for self-report, and it doesn't have to be during the interview. So some people say, well, what's the difference between altered level of consciousness and sleep-wake cycle disturbance? So if a patient tells you, oh, I didn't sleep at all last night, then you would code sleep-wake, but they were totally awake during your interview, you would code sleep-wake cycle disturbance, but not altered level of consciousness. If they were falling asleep constantly during the interview, then you would code both. You pretty much can't have altered level of consciousness without sleep-wake cycle disturbance, but you can have sleep-wake cycle disturbance without altered level of consciousness. And this is highly prevalent. Turns out not to be very specific for delirium. There are a lot of hospitalized patients, as you can imagine, with sleep-wake cycle disturbance without delirium. So just a bit about CAM-S severity scoring. As I mentioned before, each CAM feature except feature 1 is coded 0, not present, 1, present mild, or 2, present marked. So you can just total up those scores and you get the CAM-S score. So for the short CAM with just the 4 diagnostic features, you can figure it out as a score from 0 to 7. And if you use the long CAM with all 10 features, it's 0 to 19. And we've demonstrated that CAM-S is strongly associated with poor outcomes. It can actually provide additional information beside just the knowledge of CAM presence towards these outcomes. So CAM-S can be important in tracking course over time, response to treatment, and pathophysiological studies. The other little pearl, maybe Rich went over this, you almost always have better power in your studies with a continuous outcome than a dichotomous outcome. So it's good to include a severity measure as a just as sort of grantsmanship. You'll have better power with CAM-S probably than you will with just the CAM diagnosis. Okay, that's it for the CAM. Any other questions? Okay, well, you'll see more of this when we actually operationalize it. Yes?
Can you talk about the modifications you might do in someone who doesn't speak English?
In someone who doesn't speak English? So, the CAM features would still be the same. Obviously, your interview would have to be different. You would have to translate whatever testing or interview you did, but the CAM would the actual features and their interpretation would remain the same. Are you saying if you were administering it via an interpreter?
Yeah, that's my question. Just if the patient speaks Cantonese and you will do this, is just having an interpreter available sufficient, or are there other modifications?
Yeah. Well, I think it would make it more complicated, just like any cognitive testing, because now you're bringing a third party into the picture. And now it's not you interacting with the patient, it's the interpreter interacting with the patient, and sometimes interpreters can interpret behaviors and things that people say in a way that makes it more challenging. So I think it's inherently more challenging to do the assessment via an interpreter. I mean, ideally you'd have a translated assessment and a language concordant assessor that's doing that, but I realize that that can be extremely challenging. You probably want to, if you are using an interpreter, you probably want to make note of that in your research record. That's why, frankly, so many delirium studies are limited to people with English speaking.
Individual issues actually sort of individually validated in
Yeah. Yeah, no, that's true, but that's for a native, that's for someone who speaks that language to administer that. That's different than administering it via an interpreter, I think. But not having in other words, having a third party do that. I haven't seen as much of that.
Well, just that I think there is a whole body of literature on that sort of transcultural translation. And the CAM is in over 200 languages? Is that?
20.
20, over 20 languages. But it requires, it has to be someone that's interpreting it in the native language, not, I mean, that's a study, I think, you know, can be the work of a market to be translated and then to be by the same person who's interpreting everything you're saying. Is my interpretation.
Right.
So I think if you, not that you do that, but I think reviewers would want to see that you confirm that you can do that. You have some pilot data that shows reliability and doing that one versus things.
I mean, if you work in a setting where you have sort of a single primary second language, like I think in a lot of parts of the U.S., Spanish is like 80% of the non-English speakers. It might behoove you to hire someone on your research team who's fluent in Spanish and translate the instruments. In Boston, we have an incredible diversity of languages among our non-English speakers. There's no single language that accounts for more than 20% of the non-English speakers. We have about 8 different languages that constitute about 75%. So it would be really, really difficult for us to do that. But in other parts of the country, it's different. Okay, let's talk a little bit about the 3D CAM. So this is the 3-minute diagnostic interview for CAM-defined delirium. It's a short, structured assessment that operationalizes the CAM algorithm. So we only look at the 4 features in the short CAM. We started with an assessment that had over 160 items. We used actually, Rich Jones did this part, used item response theory to identify the most informative items towards the 4 CAM diagnostic features, and then use model selection items to further reduce the number of items. We wound up with 10 patient questions. There are 3 orientation items, 4 attention items, and 3 symptom probes. There's no memory because we're not coding the full CAM, just the 4 items CAM. And then there are 10 observational items looking at altered level of consciousness, fluctuation, and some additional questions on inattention and disorganized thinking. So the nice thing is you only need 1 positive item in each feature to trigger the feature. So for instance, if you asked in inattention days of the week backwards and the patient got that wrong, you could potentially end because that feature would be present. And then we use the CAM algorithm to determine the presence or absence of delirium. And this, along with everything we went over today, is available on the Hospital Elder Life website. So we did a validation study in 200 patients at Beth Israel, very old population with a lot of dementia. We wanted to purposely challenge the instrument. Everyone received the reference standard assessment, and then the 3D CAM blinded to the reference standard, and it demonstrated really good validity, 95% sensitivity, 94% specificity, retained good performance in patients with dementia. The specificity dropped into the high 80s, but the sensitivity actually even improved a bit. There is a severity tool for the 3D CAM called the 3D CAM-S that's meant to replicate the CAM-S short form severity score of 0 to 7. Basically, it doesn't require any additional testing. You just use, so if you've collected a bunch of 3D CAMs and you still have the raw data, You can use that to calculate the 3D CAM-S score. It's basically the number of errors on the different items is used to assess severity. So as I tell the story, I was very pleased that we developed this 3-minute assessment for delirium, but when I've talked to my clinician colleagues, they're like, oh no, 3 minutes, that's way too long to spend assessing for delirium. We need something even faster. So I was fortunate that Donna came down to Boston, or over to Boston, I guess, about 4 years ago to do a sabbatical, and she worked with the 3D CAM data set to try to develop ultra-brief screeners for delirium. These would be 1 or 2 item assessments to try to rule out delirium quickly. So to rule out something, you need high sensitivity. So the best single item within 3D CAM for screening was months of the year backwards, picked up over 80% of the cases. But if you combine that with a second item, what is the day of the week, you can get the sensitivity up over 90%. It's important to recognize these are not diagnostic instruments. The specificity is still only in the 60 to 70% range. Most of the people who have a positive screener will not have delirium. What we've been testing is doing this ultra-brief screener, and then in the patients who trigger positive, going on to administer the rest of the 3D CAM to see how well that works. And instead of having our research team do it, we're actually having clinicians, doctors, nurses, and even nurse aides administer the assessment using an iPad app. So that's the READY project that Donna and I are multiple PIs on, and that Erica and Priyanka, who you'll meet in a couple minutes, have been working on at the Mount Nittany site. We're also doing it at 2 hospitals, Beth Israel Deaconess in Boston and Mount Nittany, which is a community hospital like a couple miles from here. So to conclude, remember that the CAM ratings start when you enter the room and end when you leave the room, and integrate performance on formal cognitive testing with observations that you make. And there's always the patient who you come in, seems totally fine, like gets all the cognitive testing correct, and then goes off and does something really crazy just as you're about to leave the room and ends up having delirium. So you have to take the whole picture into account. Okay, so to conclude this session, this was actually a poem I borrowed from Sharon, but I thought it was kind of good. So it's a nice summary, and it's kind of a little bit of the Sherlock Holmes. So I'll read the poem, and then the question for all of you is, does this person who Emily is describing have CAM-defined delirium or not? So, I've seen a dying eye run round and round a room in search of something as it seemed, then cloudier become, then obscure with fog, and then be soldered down, without disclosing what it be, 'twere blessed to have seen. So what do you think? Do you see any CAM diagnostic features in this poem?
So they're inattentive because they're looking all around the room.
Excellent. So feature 2 is present, run round and round a room in search of something as it seemed.
And they're fluctuating because they're cloudier.
Right. Then cloudier become. Excellent. So feature 1 is present, feature 2 is present. Obscure with fog, altered level of consciousness. Okay, so feature 1 is present, feature 2, and feature 4. So we have CAM-defined delirium here. Okay, Well, if you can pull that out of a poem, then you should be able to pull it out of an interview too. So that will be our next step. Okay. So that's any questions? And there'll be time for more questions as we actually apply this. Donna?
Just could you talk about, I mean, the other thing I think you really taught me, or your group at BI, is this issue of sort of ongoing training, and can you just describe to them what you do in your weekly meetings?
Sure. Yeah, so it's important, as the upfront training is important, but then ongoing reinforcement. So the two things that we like to do, one is we have a weekly meeting of the research team where they bring cases and we discuss them. So they'll describe, you know, this patient did so-and-so. Do you think inattention was present? Do you think disorganized thinking was present? Do you think memory impairment was present? So it's good to have a venue for feedback. And then we do the inter-raters about every 6 months too, as a refresher, to make sure that everyone is, you know, remains honed in on their skills. And if we bring on a new researcher onto the team, we pair them with an experienced researcher and have them do a bunch of assessments together before we give them, as I call them, their solo pilot's license to go into the room and do the assessments alone. John?
Is there any role in the criteria for third-party data collection? So like the nurse talking about how the sleep cycle was, or the aide recording things during the night, or family reports about hallucinations, or is it, as you said, what you see in the room?
Yeah, no, it's definitely, so the place where family or nurses can be particularly helpful would be in assessing acute change, or in those two features that you mentioned that can be coded within the 24 hours. It doesn't have to be during the interview, which would be hallucinations or sleep-wake cycle disturbance. So definitely for all three of those, family members are really useful. Okay.